Ideally,
Sir, please.
Ideally, induction of a patient in a case of laryngeal papilloma has to be done with inhalational induction, especially in a pediatric age group. That too with sevoflurane. And once the patient is taken into a deeper plane with sevoflurane, then the anesthetist has to do the scopy and he has to see the feasibility, how much is the laryngeal inlet opening, and then decide on the tube and intubate the patient carefully. Since regarding the case which we have done recently, the place where the surgery was done was not having sevoflurane. It has only isoflurane. Isoflurane, by nature of its smell, it is bit tingent. Pungent odor will be there. So babies will not tolerate the pungency. So I have chosen an option of IV induction with propofol and fentanyl, and without any muscle relaxant. After the patient is sedated, I have taken into a deeper plane and then done the scopy, and I have seen the laryngeal opening. I am able to see the aperture, but laryngeal inlet is not visualized because it is masked by the papilloma, which was arising from the right.
A little bit louder, sir.
Because it is arising from the, it is masked by the papilloma, which is arising from the right vocal cord. So what I have done, when I have done the scopy, baby was bit came into a lighter plane and the baby had a cough. So when baby had cough, the laryngeal papilloma was lifted up. Then I could see a small hole at the place of the lower end of the laryngeal inlet. So I have parked the endotracheal tube near that place, and I have waited for the child to cough again. Once the baby coughed again, then immediately I could pass the tube into the space which was just below the laryngeal papilloma. So you have passed 3.5 size undersized micro cuff tube intentionally, so that it should not traumatize the vocal cords and the papilloma.
Sir, why you have chosen propofol and fentanyl? Why you have not chosen dexmedetomidine?
See, there is nothing like it depends upon the choice of the anesthetist. Dexmedetomidine, to take into a deeper plane, it has to be started little bit before only, and it has to be given at the rate of 1 microgram per kg.
How much, sir?
1 microgram per kg.
Okay.
Dexmedetomidine we are supposed to give. But if you give 1 microgram per kg without giving anything, there are chances of baby having bradycardia and hypotension also. The same work can be dealt with propofol and fentanyl, which are equally potent and equally short acting. So I have selected propofol and fentanyl, and the bradycardia episode won't be there with propofol. So I have selected.
So when bradycardia comes with dexmedetomidine, and when we are unable to intubate, the hypoxia also comes. So the bradycardia and hypoxia
will not be able to differentiate it.
Will not be able
to. So whenever you use, there is nothing like we should not use dexmedetomidine. We can use dexmedetomidine, but with caution, keeping an eye on the pulse rate.
So you want to say is the bradycardia and hypoxia both are too hazardous.
Yeah.
And what you are saying
is nothing like we should not give dexmedetomidine. It depends on the preference of the anesthetist and the scenario what we are dealing with. So in that scenario we have selected.
What is the meaning of we cannot differentiate between bradycardia and hypoxia? What exactly is that?
No, not differentiation. Suppose we are giving dexmedetomidine. Suppose we are giving dexmedetomidine. The natural tendency of this dexmedetomidine, it will cause bradycardia. suppose we are giving suppose we are not able to intubate, and because of hypoxia, hypoxia also in turn will cause bradycardia, and both bradycardia is very hazardous to the baby. So the thing is, I thought we will avoid dexmedetomidine and go for regular protocol.
Okay, this whole thing is a spontaneous ventilation.
Yes, sir. It is done and done spontaneously.
Okay, thank you, sir. Thank you.